So this discussion is going to focus on the pulmonary system. So we'll be looking at basically the entire airway, looking at the lungs, and talk about some of the different pathologies that affects the system. So just as an overview, so again, we're going to look at the, related anatomy and physiology, just like we've done with everything else, and in particular, look at the actual air exchange that takes place within the pulmonary system. Again, we're going to cover general signs and symptoms, and in particular, look at pain patterns, so we could kind of determine the cause of the individual's problems. And then go through some pertinent medical history, again, look at some procedures that'll be used for the pulmonary system and look at specific items as you're kind of going through your assessment. And then just give some brief background on some of the conditions. Again, make sure that you go through, utilize the signs and symptoms study chart, and that also has the treatment management as a part of your test preparation. All right, so looking at the anatomy of the pulmonary system, so we're going to look at the upper airway and the lower airway. So the upper airway, the nasopharynx, oropharynx, laryngopharynx, the primary responsibility of that is to add warmth and moisture and filter the incoming air. Then as we come down the airway, we have the trachea, we have the bronchi, and then eventually ending in the alveoli. And you can see the alveoli at the end of the bronchi. And we'll talk about them more later, but the alveoli is going to be responsible for where the exchange of carbon dioxide and oxygen takes place. And looking at the process of ventilation, so first of all, to just kind of define ventilation versus respiration. So ventilation is the actual physical moving in and out of air. So the actual movement of air into the lungs and out of the lungs. Respiration is actually the exchange of gases that takes place. So it's the oxygen and carbon dioxide exchange. So when we look at ventilation, just how air moves in and out, we look at pressure changes. So, air moving in and out of the lungs is the effect of pressure changes in the thorax. So when we look at that, so as you breathe in, okay, so as you breathe in, the diaphragm and the external intercostal muscles are going to contract. That's going to cause the thorax to increase its circumference. And in conjunction with that, what's going to happen is when the thorax expands, the negative pressure inside the inner pleural space is going to expand the lungs and keep the lungs close to the wall of the thorax. So that negative pressure is really important because of the fact we want the lungs to stay expanded. As the pressure inside falls below the atmospheric pressure, the lungs will draw in the air, and that's going to happen as a result of the thorax expanding. So if the thorax expands, the pressure inside the lungs is going to fall below what the pressure is in the atmosphere, and that's going to cause air to come in. That's going to allow the lungs to expand, increase their volume. Then the expiration of air is going to occur as a result of an elastic recoil, as the rib cage will compress the lungs and the alveolar pressure then exceeds the atmospheric pressure. So again, we're going to have the pressure fall as a result of the thorax expanding, and then once it reaches a point, it's going to contract and allow the person to breathe air out. As we look at muscle function, so we talked a little bit about this already. So we have, the muscles of respiration. We're looking at the intercostal muscles. We're looking at the diaphragm, okay? So the process of breathing air in is going to be a result of contraction of the diaphragm and the external intercostal muscles. Now, breathing out, it's actually it's going to be a passive process whereby, the lungs will then contract. So expiration is a passive process. You're only really going to use the accessory muscles if need be, okay? And your accessory breathing muscles, you're looking at the sternocleidomastoid, the abdominals, the scalenes, the serratus anterior, the pec muscles, the upper trap, levator scap. Those are actually all muscles that can participate in breathing, but typically they're only going to be brought into breathing when breathing becomes a little bit more labored or a little more difficult, okay? So we're really looking at, from just, breathing at rest, we're really just looking at the diaphragm and the external intercostal muscles really providing most of the control for breathing at rest. So we talked about how the process of respiration, where the exchange of oxygen and carbon dioxide takes place. And if you look down at the picture here, we have an illustration showing you how that takes place. Remember, we said the alveoli is going to be the area where that takes place at the end of the lower airway. So the alveoli is going to deliver oxygen to the cells, the red blood cells in the circulation, which the red blood cells are going to give off carbon dioxide, and again, based upon partial pressures, that's going to give that off, and you're going to breathe out your carbon dioxide. So you can see down here, they're shown in relation to muscle tissue. So obviously, all your connective tissue, your organs and everything need oxygen in order to sustain their cells. So here we're seeing the oxygen coming in, getting picked up by the red blood cells. The red blood cells within the circulation are going to give off oxygen to the tissues in the body, and then carbon dioxide is going to be given off, and then within the pulmonary system, the carbon dioxide is going to be breathed out. And essentially how a lot of that's going to happen is, again, all has to do to differences in partial pressures. So again, when we're looking at, for instance, oxygen's partial pressures in the atmosphere, that's going to be greater than the pressure in the alveolar capillaries. So oxygen is going to move into the blood across the alveoli, and then at the same time, carbon dioxide is going to move into the alveoli, because the partial pressures of carbon dioxide in the capillaries is greater than the pressure in the atmosphere. So that just means, again, it's going to go from an area of high to low. Now, there's a lot of mechanisms that are going to affect gas exchange, and when either ventilation or blood flow to the lungs is disrupted, that process of binding oxygen to hemoglobin is going to be impaired. So the amount of oxygen in the blood decreases very fast when that happens, which could lead to hypoxia and other different types of issues related to lack of oxygen. So we have our three mechanisms that regulate ventilation. Okay, the first mechanism involves the regions in the medulla oblongata and the central nervous system, and that's going to be sensitive to carbon dioxide and pH levels in the blood. So if the pH in the blood is low, that indicates chemical acidity, and a high pH indicates alkalinity. Carbon dioxide and most metabolic byproducts in the blood are acidic, and that's going to cause blood pH to decrease. So low blood pH is going to stimulate the breathing centers in the medulla oblongata, which is going to increase your ventilation rate and depth, and that's going to be what kind of balances out and raises that pH level. Another mechanism involves receptors that are sensitive to pressure that are called baroreceptors, and those are in the aorta and carotid arteries. So those receptors are going to detect changes in blood pressure. The chemoreceptors in the same areas detect decreases in blood oxygen levels. So these two receptors are going to act together to increase ventilation in a circumstance where blood oxygen concentration starts to decrease as well. The last mechanism is just in the nervous system. So the stretch receptors in the intercostal muscles cause inspiration to stop and expiration to begin. So the neurons that control ventilation in the breathing muscles, so again, we have the diaphragm, the intercostals, the accessory muscles, they travel through what's called the phrenic nerve. Okay, so the phrenic nerve gets supplied from C3 through C5. The 11th cranial nerve, okay, also regulates the sternocleidomastoid, and then different thoracic nerves that supply the intercostal muscles. So all of that is going to contribute to the process of breathing. You also have areas in the pons and the brainstem that are going to contribute to the rate and depth of respiration. So an important thing to note here is any damage to the spinal cord above the level of C3 or C4 is going to disrupt the neural pathways. And so if anybody were to have damage above that level, that's going to usually necessitate the use of a ventilator, because that's where all these important respiratory areas are for helping to regulate our breathing. So when we look at exercise and how that's going to impact breathing, so with exercise, we're going to have increased blood flow as a result of exercise, because we're going to need increased blood flow to the working muscles. So, you know, the lungs are going to be receiving more blood as a result of heart rate and stroke volume increasing. So we know that the pulmonary system and the cardiovascular system work really close together, obviously, because you have oxygen being delivered to the blood via the lungs, and then the blood being delivered to the body, which is going to allow the red blood cells to give off oxygen to the cells and all the tissue. So the lungs are going to get more blood as a result of the heart rate and stroke volume going up. And the other thing to remember is that the exercising muscles are going to be using more oxygen, okay? So given that the exercising muscles are going to be using more oxygen, the partial pressure of oxygen in the pulmonary vessels is going to decrease, which means that more of the oxygen in the inhaled air is going to diffuse into the capillaries and have to be made to the body. So that's going to cause an increased demand of the respiratory system as a result of exercising. And the other thing you're going to have is the acid and CO2 that's going to happen through vigorously exercising muscles is going to cause a reflexive increase in ventilation. So the acidity in the blood is going to go up along with your carbon dioxide levels, which is going to cause a reflexive increase in ventilation, because the chemoreceptors in the carotid bodies are going to be stimulated. So all these various things that we talked about regarding ventilation, all these areas of the body are going to cause obviously an increase in ventilation, and the increased ventilation happens almost immediately. So the body senses this even at the very start of exercise. Ventilation is going to be increased because of the oxygen demand that's going to be required. So pulmonary signs and symptoms. So some of our key signs and symptoms that we're going to be looking at related to the pulmonary system. Dyspnea. Okay, and there's an algorithm for dyspnea, which is essentially shortness of breath. So take a look at that in 7.1. So dyspnea is going to be breathlessness or shortness of breath. That's going to occur as a result of blood oxygen levels decreasing, and again, that could be due to a variety of reasons. Airway obstruction, metabolic imbalances, okay, all of those things. Cardiac pathology can cause that as well. Dyspnea caused by supine position is called orthopnea, and what that typically is a sign of a fluid shift into the lungs, or enlarged abdominal organs pushing on the diaphragm. Left-sided heart failure can also cause that. So if you get an individual, again, dyspnea is a common sign and symptom of various respiratory issues, so that algorithm could kind of take you through based upon other signs and symptoms and kind of let you know what your management of that would be. Cough, which another algorithms provide it for. Again, take a look at these. They're really useful tools in kind of making clinical decisions, in deciding, based off their other signs and symptoms, kind of how to manage that. So a cough is just a reflexive contractive of the diaphragm that just kind of forces a blast of air from the lungs. And usually that's due to some type of irritant in the lungs. So it helps a person kind of expel whatever the issue is. Hemoptysis is the coughing up of blood, okay, or like blood-stained sputum. So again, that would be something that, if that's as a result of an injury or illness, particularly to the actual structures inside the lungs, that's going to require very prompt medical attention. Cyanosis is a decrease in oxygen concentration in the arterial blood. So what you'll see with that is kind of a bluish tint in the fingernails, the lips, or the face. And that's going to happen when oxygen saturation decreases below 85%. So if you have a sudden case of that, that's going to be a medical emergency because you have a significant decrease in oxygen concentration. Thoracic pain. So thoracic pain would be another issue related to the pulmonary system. So that would be an important important symptom to note as you're kind of going through your assessment. So your pain patterns, you can see here where various areas of the pulmonary system would refer pain to, so you can make note here. Again, note any coughing, wheezing, sore throat that the person would have as well. Pleurisy is basically an inflammation of the pleura, so and we kind of see how pleurisy typically kind of presents itself in this picture here. And what's going to happen, the person will typically complain of some type of sharp, almost like a sharp kind of stabbing pain. And that could be, again, due to various causes. It can actually be due to a trauma. It can be due to infection, or even like tumors, for instance, in the pulmonary region can also cause pleurisy. So looking at your medical history and exam, again, family and personal history, just like you would with anything else. Obviously, note things like, do they have asthma? Do they smoke? Obviously, in a lot of your your really active population, your athletic population, you're not going to have hopefully a ton of people that smoke, but that's going to be an important thing to note. Again, get their symptoms. Are they having difficulty breathing? Are they coughing? Do they have chest tightness? What's their capacity for exercise? Are they able to exercise? Note in particular if their symptoms change with activity. So in other words, does activity make their symptoms worse? Inspection, just kind of generally view the area. As you look here, you can one of the things we note, do they have any type of deformity in their chest wall? So you have pectus carinatum and pectus excavatum. So you can see here. So in pectus carinatum, they have what's called a bird chest. So you have the sternum kind of protruding out. Pectus excavatum, they have what's called a hollow chest, or it's caved in. I mean, both those situations you're having. Anytime you have any type of deformity in the thoracic wall, that could create issues with the pulmonary system. Other important things to note during inspection would be, for instance, if they did receive a trauma to the chest wall, or thoracic region, note any deformities that could be due to like a displaced rib fracture. Also note any type of scoliosis that an individual would have, or any asymmetries in breathing. Okay. Which takes us into looking at their breathing patterns. So look for any type of abnormal breathing patterns. Do they have Cheney-Stokes respirations? Kussmaul respirations should be noted. So Cheney-Stokes breathing pattern presents as like an alternating pattern of hyperpnea and apnea. And that's typically going to be associated with like a brain injury, heart failure, renal failure, or any type of drug-induced respiratory depression. Kussmaul breathing usually occurs with like a metabolic acidosis, and that will present with deep breathing with either a rapid or slow gasping rate. Some other things you would note as well, any type of crepitus or fremitus. So crepitus would be noted with like a rib fracture, for instance. So there'd be like a little grinding or crackling sensation in that, and typically that would indicate, it could indicate air leaking into the subcutaneous space, or it could again kind of demonstrate a fracture in the ribs. Freminus, which is a little subtle vibration with breathing, could suggest like a pulmonary edema or a pleural edema due to a pathology. Here is where you can also you can do different compression tests to test for a rib fracture. So you can do, for instance, an anterior posterior compression for like a lateral rib fracture, and your textbook illustrates how these would be done, or a lateral compression test for an anterior or posterior rib fracture. So kind of depending upon where the patient's complaining of their pain, if they did receive a trauma to the area, you could kind of note that and then conduct those tests as needed. So continuing on with assessment of the pulmonary area, so we're going to be looking at percussion and auscultation. So both of these are important parts of your assessment and can give you some clues as to any potential pathology. So you can look at the technique for percussion. I have an illustration in here that will show this. You could read about it in your book, but essentially what you're doing is you're going to be lightly striking with your one hand over different areas of the body. And I also have the percussion points and auscultation points illustrated in this lecture as well. But what you're essentially listening for are various sounds as your one hand strikes over top of your hand that's going to be placed over these various areas. And two abnormal things you would be listening for is what's called a hyperresonant sound, or almost like what would sound like when you would hit a drum, and that would indicate abnormal airspace in the thorax, like you would hear with a pneumothorax, or a dull thud, which would be due to pulmonary or pleural edema, so there's air kind of filling the space, which would kind of make for like a dull thud as you would strike the area. Auscultation is going to be listening for normal and abnormal breath sounds. So we have our abnormal breath sounds here, which you would have, and we'll talk about each one of the abnormal breath sounds. I'm actually going to talk about the normal breath sounds first, which are the three on the bottom here, the bronchial, bronchiovesicular, and vesicular. So when you're listening to these different sounds, so your bronchial sounds are what you're going to be hearing, particularly when you're listening to the areas over the trachea. And they sound hollow or like wind kind of rushing through a pipe. They tend to have a slightly higher pitch, louder intensity, and they have a longer expiratory phase. Bronchovesicular sounds are detectable typically within the first and second intercostal spaces, anteriorly and between the scapula posteriorly. The inspiratory and expiratory phases of bronchovesicular sounds tend to be equal in duration, and they tend to sound, as far as like the intensity, they're kind of in between the vesicular and bronchial. And then the vesicular sounds, when you listen to them, they're going to be described as almost like, your book describes them as a swooshing sound, and they could be heard over most of the areas in the anterior and posterior thorax. They tend to be a little bit more low pitch, soft intensity, and they tend to have a longer inspiratory phase. When you're listening to the abnormal breath sounds, or what we call the adventitious sounds, so those are sounds that you don't want to hear. Now keep in mind that if your normal sounds are heard in other areas of the lungs than I described, they would then be considered abnormal too. So when we're listening to all of these other abnormal sounds, so our abnormal sounds, rales, rhonchi, stridor, pulmonary friction, rub, and wheezing. So for instance, when you're listening to and you hear rhonchi, they tend to be very low-pitched rumbling sounds that you would hear. Rales are kind of like basically like a crackling kind of noise that you would be hearing when someone's breathing. Stridor is basically a high-pitched kind of raspy sound. Usually you'll hear that on inspiration. And sometimes you could hear stridor even without a stethoscope. That's going to be usually caused by some type of obstruction of an airway or inflammation, and that's going to be a medical emergency. A pleural friction rub is going to be heard when the visceral and parietal pleura becomes inflamed. And a friction rub is going to kind of sound like kind of like a creaking or clicking noise at the end of inspiration, and you could usually hear that over the posterior and lateral thorax. And again, the sound produced by friction rubs usually gets described as like your book describes it as the skin rubbing against wet leather. And then you could also hear wheezing as well. Through and the wheezing is typically like more of like a high-pitched whistling sound, and you could hear that during inspiration or expiration. So those would be abnormal things. And again, essentially anytime you're listening to the lungs, if you were to hear anything other than normal breath sounds, so again, getting practice listening to normal breath sounds could provide good context. And then this way here, obviously, if you hear anything outside of what's normal, and you listen to enough normal breath sounds, through practice, going through your labs and whatnot, that again, if you hear anything abnormal that just doesn't sound right, obviously, then you would know that they need further referral. So here, and this picture is illustrated in your book. So these are both the percussion and auscultation points for the anterior and the posterior thorax. So here's a picture demonstrating how to do percussion. So again, you'd be listening for any dull sounds or hyper resonant. So the lungs, when you percuss over the thorax, you should hear primarily, you should just hear a resonant sound, which would be a normal hollow sound to hear, but you shouldn't basically hear that sound be amplified. If you hear that sound get amplified, then you know that there's abnormal air kind of accumulating within the thoracic region. So again, looking at auscultation, if you look at this picture, you could kind of see they demonstrate, we had mentioned the vesicular bronchial and bronchial vesicular noises. If you look here in your areas of auscultation, again, where you would be looking to hear those sounds. So again, they're normal in those areas where you would be hearing them. You obviously wouldn't want to hear them outside of those areas, because then that would be deemed an abnormal breath sound at that point. I also mentioned here tracheal. So tracheal and bronchial both sound very similar, and they get described in those areas. Again, that's kind of like that wind rushing through a tube, as I discussed. The vesicular sounds, I don't remember if I said this on the previous slide when we were talking about this, it sounds like rustling leaves. Again, I'm just using the descriptors that are in the book to kind of give you an idea for when you get to practice. And you can see how the vesicular sounds are the ones that are primarily present as you're going through most of the area of the lungs. And then you have the bronchovesicular, which again, they kind of, from an intensity perspective, kind of the intermediate intensity as you're listening to them. Some other things to note, which I did not talk about, are bronchophony, whispered pectoriliquy, and egophony. Those are all abnormal sounds to hear. So bronchophony are clearly heard spoken words that you can hear through the stethoscope as the person were to talk. Whispered pectoriliquy are whispered sounds that can be heard. And then egophony are high-pitched but intelligible spoken sounds. These are all abnormal. So these conditions are usually going to happen when the lung and the pleural area are inflamed and filled with fluid. So they become what we call consolidated. So instead of the lungs basically being kind of, spongy, kind of having more of like a spongy consistency, they become dense and solid. So what's basically going to happen is there's going to be difficulty or the inability to exchange gases. So if you could hear any of those, that would be abnormal as well. We talked about some of the other abnormal sounds earlier, and your book actually has a summary of them, and they kind of tell you what are some common things that you would see as a result of them. And I'm using the term rails. Your book uses the term crackles. That's essentially the same thing when you're looking at those. And you also want to note any absence of breath sounds. Obviously, that clues you into there being issues as well. So if you have absent or just decreased breath sounds in general, that would be something else you would note. Okay, so looking at the medical history and exam, when we're looking at this here, your respiration rate and depth. So normal breathing in adults is about 12 to 20 breaths per minute. Again, they should be shallow, effortless, regular. Adolescents, it's going to be a little bit higher. It's going to go upwards to 30 breaths per minute. When you're looking at this, you also want to note the length of inspiration and expiration, which both of those should be about equal. Any increase in rate or depth of ventilation is called hyperpnea. If you get an increase in breathing rate without an increase in depth, that's known as hyperventilation. So those are going to be caused by two different things. Hyperpnea, particularly one associated with what we'd call a metabolic acidosis, is a medical emergency. That's going to be when the oxygen levels are going down, whereas hyperventilation is going to be caused actually by a decrease in the partial pressure of carbon dioxide in the blood, which is going to have just the opposite effect. It's going to increase the pH, and that's going to be what causes the increase in rate of breathing as opposed to the increase in depth. Heart rate and blood pressure, again, with your oxygen and your breathing, these are going to coincide with each other. So if oxygen levels are going to decrease for any reason, you're going to have both an increase in heart rate and you'll have an increase in blood pressure. The increase in blood pressure is going to be just to maintain what oxygen delivery you have to the tissues. Your peak flow meters are going to be used to measure your peak expiratory flow. And this is going to be important, particularly for your patients with asthma. So it helps asthmatics kind of monitor their asthma and helps them to monitor their airway function. So usually with an asthma patient, they're going to establish like a personal best with peak expiratory flow. And then from there, they could kind of monitor it. So in people with moderate to severe asthma, for instance, if they have a peak expiratory flow of less than 80% of their personal best, that could indicate that they have an impending asthma attack possibly. So a lot of times bronchodilators can be used to restore that. If the medication doesn't restore it, then the person will usually be held out of vigorous activity for that day. If the peak expiratory flow falls below 50, despite taking medication, that person should be transported to a hospital. Pulse oximetry is going to measure the saturation of oxygen in the peripheral blood vessels. So, and you can see the pulse oximeter on here. Oxygen saturation levels should be greater than 95%. If the levels drop below 90, that would indicate a need for supplemental oxygen to take place. So again, looking at respiration now, here I'm saying 10 to 15 breaths per minute. 10 to 15, 12 to 20 would both be kind of normal rates. Again, you also want to know the 1-to-1 inspiration to expiration. Again, if there's an increased rate, so over 20 breaths per minute, increased depth, that's hyperpnea. That's going to be due to oxygen rate decreases. And sometimes what you might see is that the depth increasing. So as oxygen continues to go down, the rate might remain the same, but the depth might increase. And again, eventually will increase based upon adaptation to lower oxygen levels. So usually what you would see is the depth increasing first, and then eventually what would happen is that the rate would increase, as opposed to what we see with hyperventilation, an increase in rate without an increase in depth, and that's going to be due to a decrease in carbon dioxide levels.